This is Tande Kadlamini, the state of Chicago. City of Chicago, state of Illinois, right?
You got it.
Yeah. Oh my God. At this time of the interview, at 10:49 on December 9th, 2024, conducting an interview for the Global Oral History of PEPFAR project. To begin, could you start off by introducing yourself and establishing your connection to PEPFAR and what years you worked for or in partnership with PEPFAR?
Yes, I'm Allison Ruark. I'm an assistant professor at Wheaton College in Wheaton, Illinois, where I teach public health. And I first started working on PEPFAR-funded programs, I think, in 2005. And most recently, I've worked on PEPFAR-funded programs in the last 5-6 years, like 2018, 2019.
Okay, thank you very much. So we're just going to start like right from this bottom, and that is briefly telling us about yourself and your family, where and when you were born, where did you go to school, etc.
Okay, so I was born in 1978 in Oregon, and when I was 10 months old, my parents moved to Saudi Arabia, so I spent my childhood there, moved back in 1990 when I was almost 12. So I had the good fortune of getting to grow up overseas, traveling to, I think I traveled to about 40 different countries by the time I was 12, and then lived in Oregon for junior high and high school. Did my undergraduate degree at Williams College in Williamstown, Massachusetts. I don't know if you want this much detail
Just
about
tell me as much as you want.
Okay.
It is fine.
So I did my master's in public health at Oregon State University, went home back to Oregon for that, and then did my PhD in public health in the Social and Behavioral Interventions program in the Department of International Health at Johns Hopkins Bloomberg School of Public Health in Baltimore.
Thank you very much for that. So let's now talk about your career.
Mm-hmm.
When did it start and how did it start off?
So as an undergraduate student, I wanted to be a doctor. There were doctors in my family, so that was a career path I was familiar with. I had not heard of public health until a summer I spent in Kenya during college. I think I was 20 that summer. And I spent a lot of time with a Kenyan medical officer who just taught me so much about life in that village in Kenya and health and disease risk and poverty and how that fed into everything. And so after a number of these really fascinating conversations, he said to me, "Have you ever thought about a career in public health?" And I said, "What's public health?" And as soon as I figured out what public health was, there was no looking back, because I was actually a very mediocre student in my chemistry and biology classes. I just struggled in them, and I thought, I'm not sure I can manage medical school anyway. So it was just a joy to find a field that really was a good fit for me. So that's where my interest in public health started. I got a master's in public health pretty immediately out of undergrad. I think I had 1 year of a gap there. And when I started my master's in public health, I was really interested in nutrition. I'd just been interested in nutrition for years. So HIV wasn't on my radar, but sometime in that first year of my master's program, I read a book by Edward C. Green, that I know you're also interviewing for this oral history project, called Rethinking AIDS Prevention. And it just grabbed my attention in a really powerful way. And after that, I was really just fascinated by HIV and just realized what a just enormous threat it was. So this was early 2000s. That would have been maybe 2001, 2002. Mm. And so after that, HIV was just the issue I wanted to work on.
Okay, thank you very much. I just want to take you back a little bit. You were saying you first heard about public health in Kenya. What were you doing in Kenya?
Yeah, so I had a summer travel fellowship from my college, Williams College. So I wrote a really loose proposal to basically say I wanted to study healthcare. And it was a summer travel fellowship that really let undergraduate students just go investigate a question, something they were curious about somewhere in the world. So I was in Kenya for 2 months, spent a lot of time sitting in a rural health clinic, just kind of watching patients come in, watching dynamics of what was going on there. Spent some time in an urban clinic in a really poor area of Nairobi. So yeah, I learned a lot. I mean, in a very unstructured way of just, now I have words for it, like participant observation. At the time, I didn't have those words, but I still think about those experiences so much. I think thought a lot since that. Now when I travel to Africa, I mostly go to meetings and stay in hotels. And when I was in my early 20s, I think I was 20 that summer, I was young enough that people invited me into their homes. I ended up living with a Kenyan family in this village. I didn't know them before. They just invited me to live with them. So I think it was an invaluable experience of kind of being young enough and having my opinions unformed enough that I just really got to soak a lot in, and people really just opened up their homes and their time and their expertise to me, like the Kenyan medical officer whose family was the one I stayed with.
Mm-hmm. Okay, so let's now dive into HIV/AIDS issues, because public health can be everything under health. So we want to be speaking about HIV specifically. How did you come to work on HIV specifically? And if you can tie that with PEPFAR,
Yeah. So as I mentioned, I really just had a change in direction from nutrition to HIV while I was doing my master's program. Ted Green's book had focused a lot on Uganda, which at the time was the only country that had seen a decline in HIV incidence, new HIV infections, or at least the only country that we knew that had happened. So I was really interested in what had happened in Uganda, and Ted had written a lot about changes in sexual behavior towards young people delaying sex longer and adults having fewer sexual partners. So I was really interested in the question of why young people were delaying sex, because the data were clearly showing that trend, and I couldn't find anything in the published literature about why, like what changes were happening. So I ended up doing my master's thesis research in Uganda, doing focus groups with young people, I think ages 13 to 16, about why young people might delay sexual behavior or sexual initiation. And a lot came out in those interviews about young people just valuing education and seeing early sexual activity as being leading to risk of pregnancy and HIV and being a threat to education. So I guess that was the first time I was explicitly engaging with HIV. Came back from that, finished, I wrote notes because it's hard for me to remember the timeline now, but I think I finished my master's in 2004 in Oregon, and really wanted to work in the field of international health, and realized I was not going to get a job in international health. I mean, I was sending out many applications, not getting any calls back, and I kind of realized the only way to get a job in international health was to move to DC and look for a job from there. So I did move to DC in January 2005, and really at that time wanted to get a job in Africa. I mean, working in the field somewhere. I never did get the kind of job that I was hoping to, but things worked out okay. My career just went in a somewhat different direction. I ended up working for an organization called Christian Connections for International Health, which is a membership and networking organization for Christian individuals and organizations that are working in international health. So kind of like the name sounds like. So I worked for them, just developing a newsletter, a monthly newsletter. I organized their annual conference. I'd been to their annual conference before while I was doing my master's. So I wasn't working specifically in HIV or specifically in any kind of programming, but it was a wonderful opportunity just to network with organizations, especially Christian organizations, working in international health and in HIV. So in that year, let's see, this is 2005. Yeah, I ended up doing a short-term project, like consultancy for Catholic Relief Services on their OVC, Orphans and Vulnerable Children programs, which was PEPFAR funded. And it was just helping them to basically put together a package of resources for their partners. And I went to a meeting with their partners in Tanzania that year. So I was starting to work in kind of work adjacent or work supporting organizations that were working in HIV at that point. And then from there, again, through CCIH and just, also in 2005, I had a short-term consultancy to help organize a conference for a number of small organizations. Many faith-based had gotten what were called ABY grants, Abstinence and Be Faithful for Youth. So again, it was PEPFAR funding, and PEPFAR held a conference to bring them all together. It was maybe somewhere between 8 and 10 organizations. I don't remember at this point. But held a conference in DC to bring them together and just talk about work plans and reporting requirements and so on. So I helped organize that conference, just a behind the scenes role, but got to be in the room and just hearing about what those organizations were doing. And I still have some really good friends in the field who've been working in HIV for 20 years, and we first met at that conference. So it was, again, a wonderful networking opportunity. And then I ended up in a longer term role for about 8 months with an organization called MSCI, Medical Services Corporation International. Do you want me to talk about that more as well?
Well, I'm just allowing you to count the different organizations. I have some specific questions for each one of them. So just continue, then I'll have specific questions if you want to let me know. Yeah.
So MSCI, that was a more kind of in the field direct role of not just working in a support role for organizations working with PEPFAR, but actually backstopping programs, PEPFAR programs. And I was based in DC, but in the 8 months I worked with them, I was probably in the field 2 months. So the program was operating in Malawi, Mozambique, and Haiti. So I got to visit all 3 countries and work with organizations that were implementing MSCI's program. So that was, just really a great opportunity to see how such programs were being implemented on the ground. And the MSCI program was somewhat unusual in that it was supporting prevention, treatment, and care activities. So they weren't funding treatment, but they were funding treatment groups for people on treatment to just help them with adherence, and also prevention and care activities. So it was a small organization supporting fairly small partners, but partners doing a fairly broad range of things. Many of those partners were faith-based. It was a range of different kinds of partners, but mostly small. And again, some really good learning for me. I hope I was helpful to them too, but it was also just really powerful learning for me to be in rural settings and see how programs actually happen, and for people living with HIV, what their lives look like in those contexts.
Okay. Thank you. You've kind of given us an overview of the different partners that you've worked in. I really want to delve into each of those partners to really understand what a typical day was, or typical job description was for each one of them. So in the same order that you mentioned them, I think the first one was the Christian International for Health in DC.
Christian Connections for International
Christian
Health.
Connections. Okay. Yeah. So let's start with that one. I want to understand your role. First of all, the organization, mandate towards the HIV and PEPFAR connection, and what was your specific role there? And perhaps some outputs, what would be the output of what you were doing there? Yeah.
So I don't remember working on any HIV specific projects with them. It's funny, I'm actually working with them again on a consultancy right now that has to do with the contribution of faith-based organizations to primary healthcare. And so I think any, big health issue, if we're looking at it, HIV is part of that. Primary healthcare globally, HIV is part of that. So I've had a long-term connection with CCIH. Mostly my role there at the time was just producing kind of resources, monthly newsletter, handling membership, working on the conference. So it was, not directly HIV related, but meeting a lot of CCIH members who were receiving that. This was the era of the first round of New Partners Initiative, where some small faith-based organizations and larger faith-based organizations were getting grants through PEPFAR to work on HIV, and some of them hadn't gotten funding like that before. So it was a really exciting time. I remember it as an exciting time of just a lot of new things happening, and of course, the reality of the HIV/AIDS pandemic was just horrific, but yet optimism and excitement that things were happening and organizations were getting money that hadn't before.
At that point, did you know about PEPFAR?
Yeah,
or when
for
did
sure.
you get to know, and how did you get to know about PEPFAR?
So I remember George W. Bush's 2003 State of the Union address, and I was watching it on the couch in my parents' house, and I just have this very clear memory of nearly falling off the couch when he announced $15 billion over 5 years, because at that point, that was the largest sum of money that had ever been pledged to a global health issue. And so I knew kind of immediately, this is big. This is really big. And I don't think there was much warning he was going to make that announcement. I certainly had no idea. I mean, I wasn't watching the State of the Union looking for him to say something about HIV. I was just watching it. And I just remember feeling like, what did I just hear? Because at that point, I was already interested in HIV. But yeah, of course, this was, I'm sure the US government was doing some things globally for HIV, but it was really just the start of the response. So yeah. So that was my first introduction. I don't think PEPFAR was named yet at that time. I mean, that was 2 years before I moved to DC, because I moved to DC January 2005. But over those 2 years, 3x5 was announced. So things were happening. It was, an exciting time for HIV.
Can you please speak a bit more? What is 3x5, just for layperson to be able to understand what you're talking about?
So 3x5 was the global initiative under the auspices of the World Health Organization to get 3 million people on HIV treatment by 2005. And at the time, it seemed like a moonshot. I mean, it seemed equivalent to when the US government, when John F. Kennedy said, we're going to put a man on the moon. I mean, it felt that audacious. And I think a lot of us in the field thought, I don't mean working like in Africa in the field, but just within the field of HIV/AIDS, I think a lot of us thought, like, is this possible? And we didn't quite make it, of course, but we certainly got a lot more than 3 million people on HIV treatment not too long after 2005. So again, it was just kind of an exciting time of setting big goals and thinking, can we do this? But the urgency of the pandemic was so great. I mean, that was the era where people were visibly, wasting away and dying from HIV. In Africa, at least, that's where my experience was. Yeah, I still have never really worked with HIV anywhere else.
Okay, thank you. So I'm going to move to CRS now.
Yeah.
You're at CRS, and that organization is directly funded by PEPFAR.
Yeah.
So tell us a little bit more. How does CRS get to work with PEPFAR, and how do they get the funds? And I mean, what's their mandate out of the different scope of work they can do under HIV? And what was your specific role?
Yeah, so Catholic Relief Services, yes, they certainly have been a recipient of PEPFAR grants. They also get private funding through private donors and the U.S. Council of Catholic Bishops. I hope I have that phrase right. I don't remember specifics of funding. I just know, many of these large, well-established faith-based organizations have been working for decades, and a lot of it with private donations. So I think U.S. government funds through PEPFAR have allowed them to do a lot more, but I also think they see themselves as having a mission and a calling that, U.S. government funding may come and go and fluctuate, but they have a long-term commitment and calling to the work they do. So the project I was working on there was just supporting partners doing programs for orphans and vulnerable children, OVC work, and it's too long ago to remember specifics, but I believe that conference we had that I went to in Tanzania, I believe all those partners were receiving PEPFAR OVC funding. So PEPFAR funding for OVC was working to mitigate the impacts of the HIV/AIDS pandemic. I mean, families that needed support due to illness and children that didn't have what they needed in terms of nutritional support, education, healthcare. And I can't even remember specifics now of what those partners were doing. I mean, my experience has been that often OVC programs, there's kind of many priorities that organizations can pick and choose from in delivering services for OVC. So no organization is doing everything. And there's a lot of needs. I mean, it's kind of, those programs need to be very broad and holistic, but but can't do everything. So my role there was to help produce resources. This was, the days before USB drives even. And I think I was putting together like burning CDs of just kind of state-of-the-art research that to try to make it easier for these organizations to access research on what is best practice in care, and also help them meet reporting requirements. So that's been a frequent theme of the work I've done too, just trying to make it easier for organizations to satisfy USAID PEPFAR reporting requirements, which honestly are often just really onerous for organizations to have to quantify, what are they doing? How many people are they serving? And I certainly understand why PEPFAR has strict, robust reporting requirements, but it can be difficult for partners on the ground. And so both with CRS and MSCI, I was trying to just help explain reporting requirements, help organizations fill out the forms correctly, basically, and submit what they needed to submit so that the funding could keep flowing.
Okay. I have a concluding kind of question for reporting, because I think that's a very important aspect for PEPFAR, because it helps us to know how well the programs are doing. But I do want you to share with us your work with Measure. I did see that there was a consultancy you did with Measure and Palladium around monitoring and evaluation and all of those kind of things. I mean, how was that experience? I'm quite keen to know about that, because that's like one of the partners that PEPFAR has been using to build capacity for implementing partners in Africa, at least as I know.
Yeah, that was in 2018, 2019. And basically what had happened is PEPFAR was changing the reporting requirements for OVC programs. Okay. So Measure Evaluation was tasked to provide technical support for that. And my particular role, so there had been a team at Measure, and then Palladium was contracted through Measure Evaluation, a team in those organizations that had been working on this issue for some time. And so I came in specifically to help develop and deliver a training to PEPFAR partners. So I did that in 5 or 6 different countries in Africa, and basically developed PowerPoints that in just really granular detail were showing partners, this is what new reporting requirements are, these are the new indicators. And it was an interesting experience because I had been out of PEPFAR for well over a decade at that point. I mean, it had been well over a decade since I had actually looked at reporting requirements or worked with organizations. And I think, reporting is kind of no one's favorite part of a program. So it's important, but tedious. So I was trying to just make it as digestible as possible and support organizations so that they could, not waste time on trying to do that, spend their time efficiently and have the ability to focus on actual implementation and the meat of what they do.
Okay, thanks. I know that PEPFAR reporting is quite rigorous. I mean, you're also just saying that being the professional that you are, and you've already worked on these kind of things before. Yeah. So it's rigorous, and then there was this change, which is the juncture at which Measure Evaluation was coming on point. Yeah. I mean, can you recall what the response was for the implementing partners for like this immense laborious process for them to have a grasp of all those different indicators that PEPFAR is looking for so that they can be able to, report as expected? What was the feeling? What were the sentiments of the implementing partners you were training about these reporting requirements?
I think very few people love reporting. And I think generally they weren't thrilled that things were changing. There were changes being made in a way that was requiring extra effort for them to understand and comply with new reporting requirements. So, I'm not gonna say that people are enthusiastic about things that they're not enthusiastic about. But I think we all understand that monitoring and evaluation is important. And I've done a lot of monitoring and evaluation throughout my career, lots of it apart from PEPFAR programs, but I really am passionate about monitoring and evaluation because I think, we have to show that what we're doing is working and that money is well spent. So I'm not sure I want to call it a necessary evil, a necessary pain sometimes, but necessary. And I think organizations understand that as well. I remember I really came away from those trainings thinking this is so complex in the real world. I mean, I could make, I don't know how long my PowerPoint was at the end, 90 slides maybe. I could make a 90 slide PowerPoint that had everything in granular detail. But in real life, how do you actually count children? How do you actually establish there were requirements about children had to receive a certain number of services to be counted? And I think all that is just really complex in the real world. And I think we all have the same goal, right? To make this as pain-free as possible and to make it useful to organizations, but yet have some accountability. But I think actually getting there is difficult. And that's been a theme across my work in monitoring and evaluation, that it is really hard to set up, effective monitoring and evaluation systems that get the job done and don't just suck up a inordinate amount of time.
Okay, thank you for that. I do want to understand, when we talk about monitoring and evaluation, at least within the context of PEPFAR, if you're aware, where does it start and when does it end before it gets to host countries to be implemented? I mean, I'm interested to know which indicators get to be selected by whom and what influences that, so that we know this is part of reporting, which is important for PEPFAR. If you know the spectrum of that, please just explain to us in granular detail.
Yeah, I think there's a lot that I don't have expertise on, or at least not recent experience with. So I want to offer that caveat. I think my general kind of assessment of PEPFAR reporting over the years, 20 years ago when I was first starting in the field, I felt that way, and I was kind of surprised to see that not much had changed when I was doing this program 5 or 6 years ago. But I think PEPFAR reporting has really focused on counting two main things: number of people trained and number of people served. And so in a monitoring and evaluation framework, I always think of inputs, that's people trained; outputs, that's people who've actually been served. But actually we want to get to the last two domains, which is outcomes and impact. And that I see as more the realm of evaluation. So monitoring is kind of the routine data collection you have to do all the time. And that's, PEPFAR partners are having to just count who did they train, if they're using commodities, what commodities were distributed, and how many people were served. But to me, that's kind of the most surface level of what we want to get at. And really we want to get at the outcome and impact. And that's a lot harder to do, can't be done routinely by every organization all the time. I think that takes more specific targeted evaluations. It just requires greater resources. And so I hope it's okay to say I have had a disappointment, just in watching PEPFAR for 20 years, that I think there needs to be more high quality evaluation done. And it's resource intensive. And I think one reason maybe it doesn't get resources is just it's maybe harder to make the case for the importance of that. I mean, what's the rationale for taking money away from direct services, from HIV treatment, from services for OVC, to put it into evaluation? And I think, of course, there's a policy aspect to PEPFAR. I mean, a lot of the people setting priorities are Congress is helping to set priorities. There's a lot of actors here with motivations, and I'm not sure they all see the importance of high quality evaluation. But I do think there have been some real missed opportunities in terms of really making the case for the value of certain PEPFAR programs. But again, I'm speaking honestly mostly with a focus, I'm thinking about behavioral HIV prevention here. And I think for some PEPFAR priorities, such as treatment, I think we have much better data to show that what we've done has worked, astoundingly well and achieved our goals. But some areas like behavioral HIV prevention, I think we just have not done the high quality evaluation we needed to do to show impact.
thank you for pointing it directly, like to what aspect were you talking about the high quality evaluation? So, because I was going to ask you, like, give us an example where that evaluation is not done in the way that it should be. I'm going to move to the last aspect of what I believe has been, well, not really second, but last, of what I believe has been your experience working with PEPFAR, the grant management aspects. I know it was not a whole lot of time you had with management of grants, but you did speak about being part of a conference or initiative where PEPFAR was calling partners that were supposed to be like responsible for funds or NGOs to build capacity or whatever what's expected of them. And also that brief experience with MSI. So, I mean, what's a typical, like, what experience did you take away from that and what did that constitute?
Yeah, so I've never personally been involved in managing a grant or actually even applying for a PEPFAR grant. So I think you're referencing the technical meeting for abstinence and be faithful for youth partners. So those organizations had already received PEPFAR grants. And the technical meeting I was at was, again, focused on reporting and monitoring, as I remember. And I think just focused on, I think in the early years of PEPFAR, there was a lot of hashing out, like, what exactly I'm thinking, talking specifically here about prevention programs, what specifically can prevention programs do? So there were questions, for faith-based partners, how can they operate within the mission of, they are faith-based, mostly Christian partners. They are Christian, but yet U.S. government funds can't be used for proselytizing, obviously. And so hashing out, okay, how do we separate like the PEPFAR program from the other activities and mission of the organization? And the role there was more explicitly spiritual activities had to be separated in space or time from HIV prevention activities. So things like that, just that organizations were having to perhaps operate in a slightly new way because of, I don't want to use the word constraints, but just guidelines of the PEPFAR funding they were getting. And they were having to figure out, what does that look like? There's another issue I was just thinking of and now can't. I remember, just debates or conversations over how condoms could be promoted. I mean, how information could be given to young people and how they could be promoted in terms of distribution. At what age is that appropriate for young people? Does an organization have to do that? Can they choose to do that or not do that? Discussions over what programming or information needs to go through parents, what is just delivered to young people. So from 20 years later, it's hard to remember the specifics of U.S. government guidelines on all that, but those were all really real and important questions that had to be worked out in those early years of PEPFAR-funded programs.
Okay, you've sort of touched on prevention and mostly FBO, like how it was one of the issues that they were dealing with, these different organizations you're working with. But I do want us to talk about your experience with those areas of FBO and HIV prevention as it relates to research, because from your credentials, I can see that you've done a lot of research across different countries in Africa and across different areas of work. So since you've completed your PhD and done a range of research and consulting, how did you develop those research interests? I mean, like, it's one thing to be working with organizations, but now focusing and consulting on that. I mean, can you just explain how you got into that?
Yeah. So I took a research position. Again, I'm having to look at my timeline. August 2006, I took a research position with Ted Green at Harvard. It was a Templeton-funded project, so not PEPFAR funding, but we were very aware of what was happening with PEPFAR and at times working with PEPFAR implementing partners in doing research. So I was in that position 2006 to 2010, I think. And this was an era of HIV treatment was scaling up in really impressive ways, but still not having much of an impact on slowing the spread of HIV. And I have to say at the time, I was really skeptical that we would ever get treatment levels high enough that it would make a significant impact on HIV transmission. I'm really glad to be wrong about that. I mean, I think it's just remarkable how much HIV transmission has fallen. Not enough. There's still work to be done. But I think a lot of that is attributable to so many more people being on treatment, and people's viral loads fall and they're not as infectious. But in those days, we hadn't seen that happen yet. So this is, again, like mid to late 2000s. And our team it was the AIDS Prevention Research Project at the Harvard Center for Population and Development Studies. And so one thing we really believed in and said a lot was we can't treat our way out of this pandemic. So we were really passionate about prevention, and particularly about behavioral HIV prevention. So Ted Green had been researching and writing and thinking for years already on what is effective HIV prevention in Africa's epidemics, which look very different than epidemics in most of the rest of the world. And one of his real theses and beliefs there, which I agree with, was that too much emphasis had been put on condom promotion in Africa, and that condom promotion, in certain populations that are really at risk, do use condoms at high levels, but nowhere in Africa were we seeing generalized populations, people in long-term heterosexual relationships. Like nowhere in Africa were we seeing high rates of condom usage in those relationships. But we were seeing some changes in sexual behavior towards, as I mentioned, what we'd seen in Uganda was actually happening in many countries in Africa, of young people delaying sex longer, and adults having fewer sexual partners. And so that's what we were really focused on in the Harvard program, just making the case for these changes in sexual behavior that were happening, and saying this is a realistic approach. People can and will change their sexual behavior in the face of a deadly epidemic, and that especially partner reduction could have a really decisive impact on the spread of HIV. So we were working also with UNAIDS in those years, with the World Bank and their HIV unit, and many organizations were actually kind of investing in research of multiple and concurrent partnerships and in programming that was trying to educate people about the risk of sexual networks, and encourage people to reduce number of sexual partners. So that was after my master's research. That was the next time I was really engaged in research. And we weren't evaluating individual programs, really. We were largely documenting what we felt was already happening, much of it through churches and faith-based organizations, and trying to make the case that this is a productive response. But there were a number of initiatives in those years that were focusing on partner reduction and educating people about sexual networks. So yeah, it was a focus within HIV prevention interventions.
I am interested to find out the reason for the ambivalence. I mean, I think this is something that we've come across, that initially it was not very comfortable. It was worrying that, doing treatment in Africa might have its own challenge. I'm just interested to know, like, from the perspective of your organization, because you're affirming to the fact that also you shared the same view. I mean, what was the most worry challenge that treatment might not be possible in Africa?
Oh, why was I skeptical that we would ever get high enough treatment rates?
Yes.
Yeah. I think, let me rephrase that. I think my skepticism wasn't so much about getting high treatment rates, but if we could get 75% of people living with HIV on HIV treatment, which is where we're at now globally, would that make enough of a difference to this, to the onward spread of infection? Because I think we just didn't have the population level data at that point to understand, if we have 75% of a population on treatment, how much does that actually lead viral loads to fall, and how much does that actually decrease the onward spread of infection? So yeah, like I said, I'm really glad to be wrong that treatment has made much bigger difference. But I feel like in those years, I remember thinking at points, there's a group of people who believes that sexual behavior fundamentally can't change in a widespread way. And so our only hope or productive way forward is through drugs, whether it's pre-exposure prophylaxis or, universal test and treat. Um, it, and so I think there was that group of people, and then there was a group of people that I was part of that thought drugs are never actually, we can't treat ourselves out of this epidemic. We're actually never going to have enough drugs, or they're not going to make a big enough impact on transmission, and we have to focus on sexual behavior. And so I really was in that second camp, and I don't think those are mutually exclusive. I still think, we're still seeing over 1 million new infections every year. So we may, I don't know if we're at peak treatment now. Maybe we'll get above 75%, or maybe we will just keep developing new HIV drugs that are more effective and we'll see transmission fall more. I don't know, but I still believe strongly there's a place for behavioral HIV prevention. And in the years since, I've done a lot of research with couples, and I think people having respectful, nonviolent, committed relationships, I think there's just a whole host of benefits besides people avoiding HIV infection. So I'm still really committed to, I think the goal should actually be healthy relationships. And then the question is, I'm talking about couple relationships, but then the question is, what does that mean? Yeah. And not just for the goal of HIV prevention.
Okay, so I know that your focus has been primarily under HIV prevention, given the history that you've explained. But prevention is not just, about relationships quality or delaying sexual debut and all of that. So can you just tell us, because 35% of PEPFAR funding, the data is showing us that it's still going to prevention, although there's still treatment. Can you just tell us what other aspects of PEPFAR HIV prevention were there, and what do you feel about it?
Yeah. So going back to the early 2000s, or?
Yeah, in the span of your experience. You can compare then and now as you have an insight on these issues.
I don't feel very up to date on what is happening within prevention now within PEPFAR. I know there's been an increasing emphasis on most at-risk populations, which maybe now is key populations a better term now. That just tells you I'm not working in this field.
It has evolved.
Exactly, and I'm not even totally up on the terminology. In Africa, which again, it's been where I work, so I'm not speaking about the rest of the world. I think in Africa, the vast majority of transmission is still in general populations in heterosexual relationships, or heterosexual partnerships. So I think there is still just a need for HIV prevention in the general population. I don't feel as up to date on what's happening there now. I think, it's all needed. And PEPFAR, famously endorsed the ABC approach, which to me was broad, comprehensive, and sensible, recognizing that different populations need different emphases. But I think within the field of global HIV/AIDS in the early 2000s, I think there hadn't been much emphasis on the A and the B. Young people abstaining and delaying sex, and adults reducing their number of sexual partners. So obviously that was hugely controversial under PEPFAR, and ABC continues to be controversial, or more. We aren't even using the term ABC anymore that I'm aware of, but approaches that focus on changing sexual behavior, I think, continue to be controversial. And in my mind, we need different approaches for different populations. But I think all of it was important. Yeah. And I think PEPFAR was, to me, they were very much adopting an evidence-based approach. And I think, unfortunately, ABC was seen as being some, conservative Christian agenda that I think a lot of the public health community felt like it was ideological rather than evidence-based. And I just disagreed then and disagree now with a lot of my colleagues on that. I think it was and continues to be evidence-based. And I think HIV/AIDS is always going to be political. It's always going to be ideological. It's always going to be an area where people bring in their own ideas about what is good for human beings, what is good for sexual relationships. But I think there's ideologies on all sides. I think as we debate these, we all have our biases and ideologies. It's just not true that, only the more conservative camp has ideologies and everyone else is evidence-based. I've never seen things that way.
Yeah, I think we're moving right along. I mean, like connecting one thought to the other, because my next focus was going to be the faith-based organizations
Yeah.
being like on the forefront of implementation. And as we know that Bush administration was pro-life and
Yeah.
stressed that there was certain type of so-called HIV prevention type of strategies that it's not going to support, like abortion and all of that. And you worked with churches in Africa, right? So if you talk about conservatism and religion, so that place it was more prevalent. So I'm
Yeah.
interested to know, like, what was the first of all, like, what was the initial work that churches were doing around HIV prevention when you had the experience in Africa?
Yeah, I feel that I've mostly worked with faith-based organizations rather than churches. And sometimes the faith-based organization is an arm of a church, like an arm of the Anglican Church of Uganda, for instance. But I don't feel like I have a great perspective. I mean, I wasn't living in Africa to see this is what churches were doing pre-PEPFAR and how that changed. I do think, I remember thinking in those years, in the mid and late 2000s, that there was this whole debate playing out in the US over, abstinence and be faithful versus condom use. And, and people were really kind of pitting them against each other and staking out pretty rigid positions. And I think on the ground, I just wasn't seeing that same conflict that I think, I think Christian organizations, which is the vast majority of faith-based organizations I've worked with in Africa, do have values that derive from their religious faith and values about what sexuality should be for, but also they live in the real world. And also, I think many faith-based organizations want to see people, including young people who are having risky sex, have access to HIV prevention, including condoms. And so I guess I feel like, lots of faith-based organizations were operating a lot more pragmatically than they were being portrayed as in. I think there was, this perception maybe among some factions in DC that faith-based organizations were denying young people condoms and, forcing them into some really restrictive sexual mores. I think faith-based organizations were largely just operating pragmatically according to their values, but not carving out hardened positions. Yeah.
Okay. So in some of the research, like evaluation of programs, if I recall well, there was some kind of consultancies that were focusing on that. I mean, unless I'm wrong. Is that the case or not? Like, I don't know, was it Malawi and I mean, if you don't remember, of course, the recall period is quite long, for more than 10 years. So you might not necessarily remember everything. But if something does jump out of your head in terms of, I did an evaluation by this faith-based organization, and there were these glaring issues about like what PEPFAR was proposing, or there was a conflict, and this is how it was managed. But if not, then I mean, that's okay.
Yeah, I'm trying to think of PEPFAR specific projects over the past 10 or 15 years. I haven't been as involved in HIV prevention, like implementation, since the Harvard project. So mostly I was observing things more as a researcher and talking to partners, but not directly involved in evaluation of a
Okay. So let's just move a little bit into like the use of the research that you've worked on, which is mostly prevention, behavioral, strategies towards a response to HIV/AIDS. Could you tell us like some of the findings that you were able to get from the field data as you were, promoting or researching about behavioral changes?
I think I've already described in the Harvard project that we were really just documenting changes in sexual behavior. I mean, in abstinence, be faithful, and condom use that were happening in various countries. And we were also seeing HIV infections decline in some of those countries. And again, this was before treatment had scaled up enough to really have a prevention impact. From there, I got into couples research, and basically that pivot happened. I mean, I still work, my research now still is with couples living with HIV, but I just became more interested in questions of, okay, so mid and late 2000s, there were some really high profile behavior change campaigns in Southern Africa to encourage people to reduce their number of sexual partners, or at least not have concurrent partners. And I started to think, okay, what is a relational context of that? I mean, I know that's the right epidemiological answer, that if people reduce their number of sexual partners, we are going to see HIV transmission decline. But what kind of a relationship does that happen within? And I became a lot more interested in questions of just couple functioning and how can we help couples develop the kind of respectful, low violence, like just mutually kind of intimate and committed relationships in which they can be sexually faithful. And so my research has gone down that track of just understanding couple relationships. Since then, I went to Hopkins and did my PhD and my dissertation research in Swaziland then, Eswatini now, I mean, same country, was looking at couple relationships and what people want in their relationships. And I do think those questions are just really vital to this whole area of HIV prevention. I mean, whether we're talking about, well, not just prevention, whether we're talking about prevention, testing, or treatment, I think the functioning of a couple relationship matters. I mean, couples can't, or an individual in a partnership can't effectively stay on treatment if their partner doesn't know that they're on treatment and isn't helping to support them. So I think across just the continuum of behavior change we want to see happen so that people can either avoid HIV or live positively in it and live long, healthy lives with HIV. I think there's behavior change kind of at every stage of that continuum, and that couple relationship functioning matters to all of that. So that's been my focus since. And now the research I'm engaged in, which is NIH funded, is there have been various projects with couples living with HIV in Malawi and looking at factors that are helping them be adherent to their treatment, reduce alcohol use while living with HIV, all these questions of just what helps people actually succeed in treatment. It's more than just making treatment available, right? I think there's a lot that's happening in the individual level, household level, relationship level that is critical to whether people succeed or fail when it comes to taking HIV treatment long term. So yeah, that's my focus now, and really seeing that strengthening a couple relationships just pays a lot of dividends for HIV, but also a lot of other things. So another current project we're working on now is again, older couples in Malawi living with HIV and also hypertension or diabetes. And so there's huge issues of treatment adherence for those cardiometabolic disorders, and they're having to manage multiple serious lifelong chronic diseases that have kind of complicated treatment regimens. And again, like couple relationship functioning, what's happening within the family and couple matters to that. And I would love to see us just have more of that kind of broader lens when we're looking at HIV. I mean, one thing I've thought for years is I think in the HIV community, we really focus on this one disease and kind of we're, laser focused. We want to avoid new HIV infections and help people get on treatment and live well when they're living with HIV. Those are such important goals. But I think often people living with HIV are living with a whole multitude of concerns, and HIV may not even be the top of their list. They may have a lot of other concerns, such as they want a healthy relationship with their partner. They want a healthy family. They want their kids to be in school. They want enough food in the home. And so, yeah, within HIV, sometimes that's my critique, that I think we are really laser focused and just need to expand our focus to what other things are going on in people's lives that are also really important. And if we can work on those, that's also going to help us with HIV.
That is such a fundamentally important aspect, I think, because it's very easy to just run with those kind of indicators that are quant, and you've given so much treatment to so many people, and 95, we're here. But there's other things that happen, and in the background of that, and the human relations and quality indicators of couples and whatnot is just one of them.
Yeah.
How, if you have done so, first of all, who has been the consumer of your research? Who have you been able to feedback this kind of research findings, has it led to anything? I mean, in terms of changing policy, who does it reach, and what efforts are you doing to make sure that that kind of research or the perspective you're sharing or coming from the field gets to result to a change of strategy of policy?
Yeah, I think that's always such an important question. Like, who is reading the research we do? And my whole career, I feel I've had one foot in academia, more academic research, and one foot more in implementation, monitoring and evaluation, implementation research. So I think I have to kind of answer this question both ways. When it comes to monitoring and evaluation work I've done in implementation research, I think often that is helping an organization understand their work better, and hopefully also making the case to the donor that what they're doing is effective. So a recent project I've worked on in the last 2 years was for World Relief, faith-based organization, actually World Relief Kenya specifically, evaluating a program they have for couples that is focused on somewhat on HIV, but also on family planning, on building mutual respect, on reducing violence. In the spring, I got to present that evaluation to a partners meeting that USAID representatives were at, and also other organizations. And so I do see us specifically within the field of couples work and couples interventions. I do see us kind of building a research base, learning, a number of organizations learning together how to better work with couples. And it was exciting to have some members of organizations I didn't even know come up and talk to me after that presentation and say, this is so useful. We're working on similar things. One way I think my work has been able to contribute is just developing tools to measure couple relationship quality. And that's sometimes the most useful aspect for other organizations doing the same work. How can they measure if this is working? Well, I kind of have a toolkit at this point of scales that are measuring trust, communication, sexual satisfaction, various components of a couple's relationship. And we're further there than we were 10 or 20 years ago. So I'm encouraged to see that. So I think that's one way I feel like my work has hopefully contributed. In the more pure academic research side, I mean, I always think, is it dozens of people reading my articles? Maybe, it's not thousands. That's how most academic research works. But yet I am excited when my articles get cited and I look at what other people are doing and I think, okay, they're hopefully gaining something from the research I'm publishing in. And again, part of that is developing tools. So one of the outputs I'm most proud of these last few years, the research I work on in Malawi now is under a PI at University of California, San Francisco, Amy Conroy. So she and I work together on developing a scale to measure sexual satisfaction, because we felt like there wasn't an appropriate tool to use in African populations. Often we're adapting tools that have been developed for use in the US and other high-income countries and adapting them for use in African settings. But in that case, we just didn't feel like there was a good tool to adapt. So we were able to develop a tool that was published in an article. It's freely available. I know of some people using it. I hope there are a lot more people than I know about who are using it. So I think slowly we are building an evidence base that wasn't there 10 or 20 years ago in some of these areas. But I feel like it's always a really slow process for research to trickle down, into first we have to do it, then we have to write it up. That takes years, and to trickle down to actually being useful and changing things within the field. It is a slow process.
So, PEPFAR, you have a perspective of host countries implementation. You've been in Africa. You know what's missing, and that could really enhance PEPFAR, for instance, like the behavioral change indicators and strategies and support, because it's not as optimal as it should be as far as your assessment is concerned. Do you think there is an opportunity for you and other researchers that, in the field, this is important, bring it to the attention of PEPFAR? Is there anything you can do about it? Have you thought about that or not?
Yeah.
What can you say about that? Because, we can keep coming up with good data that could change the program and the outcomes. But if the right people that have the power to make those kind of decisions do not know, I mean, then it's
Yeah.
not going to result to any change. I mean,
Yeah.
what's your thought about that?
Yeah. I would love to see PEPFAR just expand its vision. And again, it would be audacious, but it was audacious 20 years ago. To expand its scope to look at more diseases and health concerns than just HIV. And I think we all know that there's this rising tide of non-communicable disease. I mean, cardiometabolic disorders, hypertension, diabetes, and I think we know there's this rising tide across lower income countries, and we're not responding to it effectively. And I've been struck, this more recent research I've been involved in Malawi, again, couples that are living with HIV and a cardiometabolic disorder, the treatment and care they're receiving for HIV is so much better than they're receiving for these other diseases, because PEPFAR and other initiatives have just done an outstanding job of strengthening treatment and care for HIV. But the healthcare system itself, and that has, I think, kind of lifted all boats when it comes to the healthcare system. There have been benefits to just strengthen across the board healthcare systems, but the healthcare system is certainly not strong enough when it comes to providing long-term treatment for other non-communicable diseases. So it's just been striking to me, at least in this study population in Malawi, that people are much more concerned about diabetes and hypertension and much more concerned about dying from them than they are from HIV. So I think there's so much more work to do. And again, I think PEPFAR has been, so successful, but also had a narrow focus, which maybe was absolutely necessary 20 years ago when there was just such a mandate to get drugs to people and stop this, horrible, just the catastrophic death rates we were seeing. But I think we're going to start seeing just higher and higher death rates from other diseases as well, unless we start taking them seriously. And of course, these diseases they're not just co-occurring, but people living with HIV have higher risk of other cardiometabolic disorders, and treatment for one disease can complicate treatment for other diseases, or certainly not having effective treatment for cardiometabolic disorders is a threat to the health of people living with HIV. So I think we can't separate them. I think we so often just work within silos in international health, and that's not my original observation. We all say that, but what can we do about that to really work towards comprehensive care? Yeah, and as I said, I think we just need a broader lens too. What does it mean for people to flourish, for their families to flourish? I think we're seeing mental health as just an increasing threat across the globe too, and something that also intersects with, of course, HIV and other chronic disease that people are living with. And so I think, our end goal needs to be people flourishing, living longer and healthier lives. And what can we do to get people there? And maybe that just takes a broader lens.
Okay, I think my specific question that I'm interested in would be, have you had opportunities to feedback this kind of research finding from the field to PEPFAR with the hope that they incorporate it in terms of maybe change budget or the strategy or what have you?
No, I mean, I'm pretty out of PEPFAR and USAID world at this point.
Okay.
I will say I'm encouraged that this research in Malawi is NIH funded. So NIH is, seeing the value of working with couples living with these cardiometabolic diseases and HIV. So I think, that encourages me that this is priority enough to get research funding. Of course, NIH research funding, that's very different than programs getting funding, right?
Okay.
Yeah.
There is some aspect of gender in the work that you have done.
Yeah.
I mean, is there anything that you want to say about what you found to be glaring issues around gender and HIV in Africa, just as we wrap up your experience, to go to more general issues about your work in Africa?
I think it's been so obvious since early in the pandemic that gender is a huge part of this, and women's status and lack of power is a huge part. I think sometimes we make the mistake of using gender to refer only to girls' and women's particular issues and challenges, which again are so just glaring. I mean, the reality of gender-based violence and just women's lack of power, lack of access to decision making and resources within the household. Those things are so glaring, but we also know that men are lagging behind on diagnosis and treatment for HIV. So I think we can't just boil gender down to being only the concerns of women and girls. One reason I believe so strongly in a couples-based approach is I think if there are power dynamics within the household, within the couple, just trying to empower women doesn't work on its own, because if it's just leading to more conflict and more violence or aggression towards women within the household, we haven't achieved our goals. So I think when it comes to gender, that's another area that I'm just a huge proponent of working with couples and recognizing how both may be disadvantaged in different ways. I mean, men need to be into treatment more. They need to be just engaging with the healthcare system more. They need partners to encourage them to do that. So yes, gender has been a huge part of this. I think we want to see everyone empowered, everyone getting the best treatment and support and care they can.
Okay. So since PEPFAR started, it has gone through different presidential tenures, and there's been reauthorization that needs to take place, and there's been arguments for this and that and all of that. Have you really followed how that trajectory has been, and what's your impression of it? What do you think is going to happen? And if it does not get authorized and all of that, what major concerns should be there? So if you can share your view on that.
I don't track what's going on at PEPFAR nearly as closely as I used to. I mean, I still have friends who are working in various PEPFAR funded programs, and so sometimes I hear from them. Last year, I was so horrified by the debate over would PEPFAR be reauthorized. So, when I see it in the headlines, I kind of go dig into what's going on now and then. And I think, of course, the huge issue there is just people being able to stay on treatment. And that's what really horrifies me, that we have an existing commitment that we absolutely cannot renege on to people who are on treatment. So I hope that we just continue to recognize as a country that is a commitment we have to keep. This is not a partisan issue. I really do feel concerned about, I think the debate last year made me think, this could happen, that PEPFAR might be deauthorized or at least funding decreased. I'd like to think that couldn't happen in, America in 2025, but who knows? So I think, keeping that commitment to people already on treatment. I know from the little I hear about this, I feel like there's also concern across Africa from governments and partners there of what is the contingency plan if they can't count on funding from the US and other global partners in a long-term way. And so I think it's a good shift for countries to be thinking, how can they fund those activities themselves? But I also know that just even as the cost of treatment has fallen so much, still the cost of treatment is just an astronomical amount for a lot of countries compared to their overall health budget. So that just is what it is. Yeah.
Do you think there is any role that can be put in place, except depending on this being a bipartisan issue, within the four walls of Congress? Is there anything else that can be done to make sure that there is no change, the U.S. commitment to this continues? This is purely your personal perspective of this. Do you think there's anything, or is just putting all of our hope that people will be able to support this within Congress as they're debating the issues?
I just get really discouraged over this, because I feel like I end up in conversations with friends and relatives, Americans, people I love and think are fundamentally good-hearted and compassionate, who just kind of don't get why we need to be funding programs in other countries. And, I hear responses like, but so many people here need resources. And that's true. I'm also very concerned about the fact that not everybody has the access they need in this country to healthcare. But I think people don't understand, seen over the years, surveys are done with Americans on what percentage of the US budget they think goes to foreign aid and development, and they always overstate it by like 10 times. I mean, they're not even close. And so, I looked up this morning, how much are we spending on PEPFAR now? It's 6.5 billion annually. That's less than 1% of the US defense budget. I mean, it really is a small amount compared to our overall budget as a country. And I think people don't understand that. I think people react against it in this protectionist, we need to conserve what we have for Americans, but based out of a really false assumption that somehow foreign aid is 10% of our budget. And it's just not. It's a tiny part of our budget. So I wish that's a point I could get across to people. I think people generally aren't good with numbers, not good with big numbers. We talk about like, what is a budget of $6.5 billion? And we don't have a sense of scale. It sounds like a lot. I wish I could just get across to people, this is a pretty small drop in the bucket, and it is doing so much good and literally just keeping people alive to be parents and spouses and, productive members of their society. So I think if you were to ask people, do you want, is it okay with you if people anywhere in the world die of a preventable disease and leave their children orphaned? Nobody's okay with that, but yet we also somehow aren't okay with putting a small amount of real money towards an act of compassion for the world.
Gotcha. Okay. So now reflecting back on your work and attention to HIV work in the last 2 decades, what would you highlight as PEPFAR's biggest achievements and shortcomings? I think you've sort of touched on it, but if you can like put a nail on it, what would be like the takeaway message of like, this is the greatest thing PEPFAR's done, and this is like acutely shortage, and this is what needs to be done?
Yeah, I think it's just been phenomenally successful in getting people on treatment and also in caring for families to some degree through OVC programs. I'm kind of more measured maybe in my evaluation of the impact it's had on prevention. And I think part of that is just that we don't have good enough data. Again, coming back to the question of evaluation, what have we really accomplished? I don't think that we have done the kind of research and evaluation that we really needed to do to prove that we have, that those prevention programs have had an impact. But I also really appreciate, having been a researcher and evaluator for a number of years now, I also really appreciate how difficult that research is. And just to give like one example, I've been involved in evaluating multiple programs for couples, not PEPFAR funded necessarily, but that were aimed at changing sexual behavior and increasing relationship quality. And as I've evaluated those programs, usually the outcomes are mixed. And we always ask questions like, if we could follow couples for another year, would we get better data? Or if we'd had a bigger sample size? But that's all to say, I get it. It's not like there's some magic bullet that if we could just have PEPFAR prevention programs all do this, particular type of evaluation that I design, that they would get the data they need. It's not that simple. It's complex. I guess I wish that we were further when it came to understanding how to evaluate complex behavioral interventions. And I am kind of discouraged that we haven't gotten further in the last 20 years. And I think it's been a lack of investment and vision for that, honestly.
Yeah. So I know that you're a social epidemiologist, and it's not just all about treatment and all of that, hence your interest in people's lives and their quality of interactions and all of that. Do you see that, generally, if the influx of aid to these societies supporting these different interventions is changing, like the institutions, for instance, would be like organizations, the cultures, like how they do implementation and how their view of like the different aid funding organizations are. Is there anything you can say about, is there any transformation you've observed?
Of the funding particularly?
Yeah, like the coming of the funding and shaping the culture of the organizations and how work gets to be done.
Yeah. I haven't worked in health facilities a lot, and I think, I believe kind of the consensus that funding for HIV has really just lifted all boats and strengthened healthcare systems. So I think there has been that transformation. I also think there's just been strengthening just the technical expertise of professionals in a lot of countries. I mean, I think a lot of good work has been done in HIV, and I think hopefully a lot of those skills, good work done in one area, people are acquiring skills that are transferable to other areas as well. So I think just in terms of, developing technical expertise and research expertise, I hope that, what we're learning from HIV is transferring to other issues. There was another thought I had about just because I do think a lot about just, what is happening within cultures and societies. I think stigma with HIV is still a problem, is probably will always be a problem. But I do think there has been some success in destigmatizing HIV and it just becoming one more chronic disease that people can live with, that people know is not a death sentence. So I think that has been an achievement too, for people to, just understand that this is something they can live with. Some of the fear and stigma have diminished there. And overall, we are keeping, people do drop out of treatment, but I think overall we are keeping millions of people alive. So that's a huge, huge achievement, and huge achievement for, communities and families themselves and for health systems. I don't want to just frame it as that's the achievement of PEPFAR. I think PEPFAR has given money, but there's a lot of things that have to happen for people to succeed on treatment. So I think that's a success that, really also comes down to what has happened in societies and countries themselves.
Okay, onward looking on PEPFAR, and like you made an example that conversations you have with colleagues, friends, it's kind of conflicting in terms of whether the US has to continue their commitments for HIV outside of the US, as rightfully so, their commitments domestically. So that points to the fact that most people maybe don't even understand what the significance of this is, let alone know what PEPFAR is. And yet this is money derived from like their taxes and all of that. So what exactly do you think this is the case? And whose voices are missing in this kind of, in this perspective? And if those voices have to be heard, what will be done?
So I think the question is, what would better advocacy look like for the success of this program?
Perhaps.
I'm a qualitative researcher, and I do mixed methods and quantitative as well, but really qualitative research is my real love. And I just believe so strongly in the power of story. And I think individual stories can just communicate reality in a way that all the numbers in the world can't. So again, something like spending $6.5 billion a year, most of us have very little context to understand how much money is that. Even talking about how many people are living with HIV or how many people we've treated, I'm not sure those numbers really communicate well to the average person. So I think, stories about, people whose lives have been made better, who were living healthy lives because of this funding. I think those stories are powerful. I know it also takes courage for people to put their story out there, especially with this disease, and and make that public. But I'd love to see, the average American just know more about the stories behind all that. And in a way that's empowering. I think sometimes we tell stories of low resource parts of the world in a way that it can turn into poverty porn, or just like to paint it as dire as possible so that so that we're really grabbing people's heartstrings. But I think there are ways to tell stories in ways that acknowledge the challenges and also are empowering and acknowledge the resilience. And again, like our success in treatment, that is also even more so the success of people living with this disease and what's happened in those societies and countries. So I'd love to see that story just told too, not just as look at what our US dollars have done, but look at what people in these countries have made possible.
Thank you. I think that sort of conclude like the more professional narrative of and your experience around HIV in Africa and your different links with PEPFAR. I just want now to talk about your personal experience living in Africa?
Mm-hmm.
I mean, with your family, if you can
Yeah.
reflect on that, because I mean, we know that for some people that we get to talk to, some had never been in Africa before. There's preconceived views and what they experience, you know. Then it really shapes their viewpoint in life as a person, or shapes their career trajectory. So can you just talk to us about that? How was it like, you know, going to Africa, working there? You had both of your children there. They were raised for the most part for what age they are now. How was that for you? I mean,
Yeah.
can you
So
talk to us about that?
I'd been working in Africa for a number of years, spent time in East Africa. I mean, a couple months there. I'd never lived in Africa longer than that until, I have to think of the years now, end of 2012. Yeah, we moved to Swaziland for me to do my PhD research. My son was 8 months old at the time, and then my daughter was born after we'd been there about a year. So both my kids did spend their early childhood there, and we left during the pandemic in 2020. Well, after Swaziland, we moved to South Africa for about 5 years. So total time we were in Southern Africa about 7.5 years, and my kids were, let's see, almost 7 and 8 when we moved back. So it was an early childhood. I just feel so fortunate to have been able to give my kids that experience of living there. I mean, I love Africa. They grew up very much feeling that was their identity. My daughter, upon moving back, would refer to herself as African American, and I would say, "No, sweetie, that's not what that term means." But I think, yeah, for our family, it really became just a part of our family's culture and experience. I think one thing that constantly fascinates me about Africa is the more places I see, the more I realize it is so diverse. I mean, I thought I kind of knew Africa after spending all that time in East Africa, and then lived in Southern Africa, and just was constantly struck by how different so many things were. I mean, so much diversity. I'm sure.
Can you point out the difference, if you may? I mean, if something stands out on top of your head.
A lot of these things are subtle, right? I'm trying to think of a good example. I've studied family structure a lot. So one thing that was striking to me is in East Africa, a lot of rural East Africa, most households are still two-parent. People may live in more extended family structures. In Southern Africa, there's a lot of single-parent households. So that was, Southern Africa is a lot more urbanized. Even things like the media people consume, what they eat. I mean, kind of my framework for Africa was, you know, a village in which people are, the mom is cooking traditional food and they're living in a more traditional way, maybe without, you know, electricity in the home. And in Southern Africa, yeah, an urban population that may be facing challenges of daily life that are just as great, but they're in a more urban environment, and yeah, and just not living in the same kind of rural traditional way that I'd seen in East Africa. Other differences, I mean, living in South Africa is just so diverse, ethnically, culturally, and just seeing how, you know, so many different groups there have shaped that. Of course, many countries in Africa are diverse in terms of many different cultures and ethno-linguistic groups. So yeah, I think the more I see of Africa, the more I think I really can't generalize in my mind about so many things, because it just is diverse. Yeah, but how did that shape me? I mean, I think I still think so often of, you know, as I work on these issues, sitting behind my computer in the US and Wheaton, Illinois, wherever I am, I find I'm just constantly thinking of something I learned or observed in a part of Africa. And, you know, I need to ask myself the question, is that something that's helpful here? Maybe that was just that family or that person. But I just am really glad I've had the experience of seeing how life works a little more. And I think, I mean, I say I really hope for a day in which, yeah, Americans like me don't have a role in many of these areas of international health, because I want to see, you know, so many highly educated people across the African continent that kind of outsiders are not needed to in these programs in the same way. But as I continue to work on some of these issues as an outsider, I think just the time I've had in Africa is really valuable to just understand a little more, oh, this is how life actually works there.
Okay, so you've spoken about your personal, how it personally influenced your career and like your perspective.
Yeah.
I mean, and the fact that your daughter identifies as African American.
I have tried to not say that anymore.
Yeah, but of course you need to
Yes.
put that into perspective, and it's kind
Yeah.
of an era. I mean, do you find that, I don't know, schools, friends, interaction, like they have a broader view of
Yeah.
life, as it were, like in comparison to your nieces or nephews that have
Yeah.
not been outside of the US
Yeah.
and they only just have a perspective of the US, for instance?
Yeah, I hope so. I mean, I think so, and I think a couple of values I'm just always trying to instill in them as, look for at school or wherever, look for the stranger, that person who isn't from here. Here in Wheaton, Illinois, we have a number of quite a few actually refugees and immigrants that have been resettled here. Some of them are in my kids' school. I want them to be able to see them as kids who were in a strange place and need friends, because that was my kids' experience, when we were South Africa. So I hope they just have a more kind of inclusive and welcoming view towards the world. And yeah, just seeing themselves. I mean, they both kind of say to me at times, they feel like they don't really belong anywhere. That's a third culture kid thing, right? I grew up overseas. I get it. But I think in some ways that's really a gift to always feel a little bit on the outside, because you can, hopefully help connect and welcome other people that are a little on the outside as well. And just be able to relate to people. Yeah, if you're always a little on the outside, you can have something in common with a lot of people rather than, just feeling so part of a culture that it's harder to relate to others who aren't part of it. So, yeah, I hope they grew up speaking some Afrikaans. They can't speak that anymore. I hope that some of those neural pathways in their brain that help them learn languages are still there, and they still have lifelong friends. Some of their, oldest friends who come from different cultures, whose skin is a different color. I hope those relationships endure as well.
Big joys and struggles that you encountered as you were there. I mean, outside of professional experience, like as a person coming into this. Like for instance, why Swaziland for your PhD? And what were your struggles there? What were your greatest joys?
Yeah. So why Swaziland? That's an interesting question. I mean, I was really interested in studying couple relationships and how basically changes in couple relationships were fueling the spread of HIV, and particularly increasing norms of people not being in long-term committed sexual partnerships. So Eswatini was one of the countries in the world that had Southern Africa has the world's highest HIV rates. And so Eswatini was kind of on that list of countries with the most dire, serious HIV epidemics. And also, I'm just fascinated by these shifts in culture. Like, why is marriage and just long-term committed sexual relationships, period, becoming less normative? And I think that's a really complex story, right? It's not just about individuals and their choices. It's about economics. It's about economically driven labor migration, where people have to go work in cities. So that's a complicated story, and I knew that even when I went there. But yeah, Eswatini, Swaziland at the time, seemed like a small enough country. It is a small country that I could have a project and kind of have it be a more kind of limited scope of looking at this particular smaller country, fairly homogenous population and culture. I mean, every country's diverse, but it wasn't South Africa with 11 different official languages and so on. And I had some contacts there. Ted Green, who I mentioned and has just been a long time academic mentor, he had lived there and done field work there decades previously. So I had absorbed a lot of his stories over the years, and thought, I think this is a place that I could actually productively study some of the things I want to study. And certainly in partnership with some scholars there. I mean, my project carried out qualitative interviews, like repeated life course interviews with people. I personally did not carry those out. So I was training Swazi researchers to do that. And really realized too, I was going to have to have a team to work on that.
Any big joys, struggles you encountered there?
I loved living there. I mean, I'd grown up overseas, and I just was so excited to get to live with my family overseas again. I think struggles, I think you don't become an insider in a country after a few years living in a place. I think that takes decades, if ever. So, I think it was a really complex topic, and doing research there and living there, I was always, an outsider living there and navigating that, trying to understand complex things, both in daily life and in my research. Of course, it's not easy to be far from home. I think my top advice for people moving across the world is do not do it at the end of October, because then you go through Thanksgiving and Christmas and you're just there. Exactly. So move in, January, maybe give yourself some lead time to.
You'll have friends by the time it's Thanksgiving
Exactly.
time and Christmas.
Exactly. So I remember some tears over things like that. Absolutely, it was worth it to live there. But it's living in a place, it's not vacation. It's not a fairy tale. You're putting up with the good things and bad things, the country. And I'm so thoroughly convinced that every place I could ever live in the world would have things that were, wonderful and I enjoyed much more than the US, and things that were much harder than the US. And that's just the way it is. So the friends I made there, I really value them. I just think, often we learn through experiences that aren't so easy. So I think experiences there were so valuable and worth it, even when they weren't easy. But still, I mean, I was back this summer with my kids, and they hadn't been back in 10 years. I was back in Eswatini, and it was such a joy just to get to show them that country, and it will always have that place in our hearts and our family's life.
Thank you so very much for your time. Before we close, I'd like to turn to Dr. Kelly and see if she has any additional questions. She's good. As a parting message, is there anything you'd like to say? I mean, that we didn't talk about, you'd like to say about PEPFAR or anything as we conclude?
Let me quickly look at my notes and just see if there's anything else. I don't think so. Thank you so much.
Thank you so very much for your time. We really appreciate it. It has been quite insightful, and we'll keep in touch and just update you when the interview is up in our public repository so that you can watch yourself and be happy. Thank you so much for your time. Bye-bye.